Welcome back from the short commercial break. You are watching The Health Code, and I'm still here with Julius from Limia, who has educated us on emergency care and what it entails. So, Julius, you talked about home injuries.
Yes.
And there are very many different cases of home injuries. But the most common type is we see many children having seizures from home. And, they have seizures, and people, there's a myth. I don't know if it's a myth or a misconception, but parents or whoever is at home rush to get ginger and pound it, and put it under their tongues. So first and foremost, can you call this an emergency? And if it is, what are you supposed to do in such a case?
Seizures are emergencies, and they can be life-threatening.
Yes.
But there is a myth. I remember when, as I grew up, they used to tell us that you put a spoon in the mouth. So the simple steps you can do when somebody gets the seizures, especially kids, all you have to do is make sure the environment is safe for them. You're not going to do anything to revert the seizures because you don't have the medication to do that.
Yes.
But you have to make sure that the environment around them does not create secondary injuries.
Okay, and what are those secondary injuries?
Secondary injuries is if somebody falls in the kitchen, for example, and they are having multiple seizures, then as they move, they can hit glasses and the glasses will cut them, or hot water will pour on them, so you have now burns, you're dealing with burns.
Okay.
Or if you have sharp objects around them, then you are going to deal with now catastrophic hemorrhage or
Okay.
wounds. So you have to make sure, if you have a soft environment where you can put, let's say you have a blanket, you can put it around them, clear the space around the areas, and make sure that the environment is safe.
Okay.
And the seizures will stop. So as the seizures stop, please call us to respond. So for us, when we respond, we know how to reverse
Okay.
the seizures, and if the patient does not have the known cause, like epilepsy, then we'll take the patient to a facility.
Okay, so does this also apply to grown-ups, not only children?
Yeah,
Okay.
it's everyone.
Okay.
It's everyone. So you have to make sure that the environment where they are is safe. There's nothing you're going to do about the seizures, but you have to keep them safe from getting secondary injuries. And those secondary injuries are the ones that are life-threatening, will end up being life-threatening. If the patient, for example, has glasses, just remove their glasses. Remove their glasses off. It's very easy.
Okay, so besides seizures, what kind of other emergencies, home injuries to be precise?
There are lots of, there are people who go into, for example, people who have pre-existing conditions like diabetes. They've forgotten to take their medications. Then we have, we have cuts, we have folds. Those are the most common. Cuts and folds, catastrophic hemorrhage, especially in children. They play around and then they get injuries. People who are working on a construction site, people who are sick. Then we have also heart problems.
Okay.
We've been called for multiple cardiac arrests, but sometimes the time people call you for a cardiac arrest is usually too late.
Yes.
So people tend to do, for a cardiac arrest, you need intervention to be very, very fast and swift to be able to revert the process.
Okay, so you said cardiac arrest. This is something that can instantly kill someone.
Cardiac arrest is the heart stopping to beat.
Yes.
So you have died, actually, technically.
So
died.
what do you give medical advice, or rather should I say, what do you tell these people that probably have called and they need to revive that patient there and then? What do you do in such a situation of a cardiac arrest?
We have systems that we use. When we go to the call center, I'll show you how it works. you can do CPR. CPR is cardiopulmonary resuscitation. So you can resuscitate the patient.
Okay.
So if the heart has stopped working, then you have to act as the person's heart to be able to bring them back to life.
Okay.
So the person is going to die not because the heart has stopped, but because the oxygen around the body is, the parts of the body is, or the brain is not receiving oxygen.
Okay.
So the best way to do it is to do a chest compression. So chest compressions will keep that patient going until when we come. So when we come, we'll give medications, we will shock the patient and shock the heart into rhythm. But if you do an early CPR, you give the patient chances of survival.
Okay.
High chances of survival. So, but if it takes time, then it's very hard to resuscitate the heart. It's very, very hard. So that's why when somebody calls us, we'll take them through a process of how it's done. Yeah.
So instances such as drowning,
Yeah.
you know, and we need to revive this person.
Yes.
What do you do in such instances? Like I said, an emergency has occurred, and I've called the call center, the toll-free number,
Yes.
and I need to find a solution for this person before they leave, you know, before they die. So do you give like instructions for people to follow
Yes.
before you get
We
there?
give clear instructions. They are called pre-arrival instructions. So the pre-arrival instructions are instructions given to the bystander or the caller in order to maintain the patient until the paramedics arrive. So it's that gap. So we need to bridge the gap. How we bridge the gap is we give those instructions, we call them PAIs, pre-arrival instructions or post-dispatch instructions.
Okay.
Those help the patient, those help the bystander give aid to the patient as we wait for the paramedics to arrive. And we usually keep you on phone. We don't let you go until the paramedics arrive. Because the moment you leave, for example, if someone is giving CPR, we will ask, when you leave, they do their thing, say, hey, ambulance here too, say, and they want to run out. But as you run out, that window could be the difference between life or death.
Okay. So, you know, I watch a lot of movies, and I watch a lot of medical movies, and we see that abroad, in the US and very many other countries, this service is very common.
Yes.
And we just want to know, is it common in Uganda, or rather, how are Ugandans responding to it? Do they see the need for these emergency care services?
There's a need and there is a huge knowledge gap. That's the difference between Uganda and the rest.
Okay.
So I've studied in the Netherlands and I've lived in the Netherlands, lived in Europe for a long time.
Yes.
So in schools, they teach you from zero. You have to call 2111. You have to call 911. So, sorry, 112, or you have to call 911.
Yes.
Now, in Uganda, is either you call your neighbor or you put the patient on a board and take them to the hospital.
Yes, that's true.
But when you carry the patient, there are patients that are very unstable.
Yes.
They're very, very unstable. You move them, you kill them. Now, if somebody has fallen from a building, when we respond, we know how to move that patient. There are ways we move the patient who has had such a fracture. Because when you move them with your hands, you're likely to injure them, aggravate the injury.
Yes.
So when we come, there are things we do. We can't deal with the primary injury in the field, but we stop the secondary injury.
Okay.
If somebody has fallen and maybe they have broken their skull,
yes.
we're not going to do anything to deal with the injury, the skull.
Yes.
But we can stop, for example, brain swelling by intubating that patient, because if you have such an injury, you really do not want to be your brain thinking about your children, because as you think, the brain is in a rigid box. As you think, you're putting the brain to work and it will swell.
Yes.
So you need, that person needs to be put to sleep. And when they are put to sleep, but how many people can do that here in Uganda?
Yes.
So we actually introduced the pre-hospital care standard in Uganda, that we can bring the actual hospital to the patient.
Yes, yes.
Yeah. If you look, our systems are actually more equipped than most of the emergency rooms in most hospitals in around town. Yeah.
Okay. So, Julius, in 2020, COVID, this was a tough time for very many people, and a lot of emergencies were being seen, and very many people are being rushed to hospital. How was the COVID-19 response with Limia, especially?
I think it was an eye-opener to the public, because we started the campaign in 2019. We started in 2019 around December, and we took it around. We did a lot of campaign on how emergencies are. People thought, it's even now, Ugandans think an ambulance is a vehicle that takes you from point 1 to point 2.
Yes.
It's actually the other way around. An ambulance is supposed to be a hospital on wheels. It's supposed to be bringing the whole hospital to you,
Yes.
and then taking you from there, from pre-hospital care into definitive care. So definitive care is in the hospital. We're not going to do a CT scan in the field, because we can't do that.
Yes.
But we're going to do all that is needed in minutes to save your life. And then we take you to the hospital, they will take it from there. They will do the surgeries from there. But we can do, for example, surgeries that will save you from dying. Then we give you a high chance of survival. For people who have, let's say, trauma patients, we give you not only the chances of survival, but we give you the chances of living a normal life after that.
Yes.
Yeah. During COVID, we had issues where people used to rush patients to the hospital.
Yes.
And then they would call us, because we specialize in critical care. So they would call us when they all have failed. But then, because we had around 4 patients who had to intubate, they were brought to the hospital, rushed to the hospital with an ambulance, with the A-type ambulance. And they were dying because the hospitals were not informed, they didn't have the beds, and these people were decirculating to death.
Yes.
So they needed to be intubated. So they called us, reaching there, and you find somebody needs to be, you intubate the patient, but you don't have an ICU bed, so you have to keep the patient in an ambulance, exchanging ambulances for all. I think one was, the longest was 16 hours.
Wow.
He survived.
Oh,
he made it.
That's great. We see that during COVID time, there was a lack of oxygen, and very many people are contacting different relatives. And earlier we had a conversation, and you told me they would even call you. Yeah. So how did you deal with that?
So for us, when they called us, we had systems. We have a system called the hospital at home. So we take the hospital to you. So we can go home, set up a hospital, and then you are on call, because we could respond in minutes to make sure we take all the equipment and necessary things you need. But most people wanted to do it themselves, which is usually hard, because it's not about giving oxygen. It's also about monitoring the oxygen and how you're giving it. So you're giving the oxygen, but how are you giving it is the question. Is the patient receiving the oxygen? So we have around multiple ways of giving oxygen. So you just don't give the oxygen, you have to see whether the oxygen is effective. But what the mistakes people used to do, they wanted to do it themselves, and they failed. It was catastrophic. So they call you at the last minute, and you reach home, you have to intubate the patient, you have to get them in the hospital. But had they called you earlier, you would make decisions on whether this patient requires to go to the hospital or could be handled from home. But people wanted to do the shortcuts as it always
Yes, yes.
done here, and we lost a lot of lives. But we learned a lot. At least people now have a clue when you talk about emergencies. They still understand, but we still have a problem that we learn, and after a few minutes, I call them short learners. So we learn when we have a problem. When the problem is done, we forget. Yeah, so we tend to be very short learners.
Okay, thank you so much, Julius. Well, you've heard it from Julius that Ugandans, there is still a huge gap of Ugandans not knowing about the emergency medical care services here in Uganda.